Well, welcome. My name is Todd Villines, and I'm the Chief Medical Officer at Elucid, and we are thrilled to sponsor the SCCT webinar. This is part one of a two-part webinar series. The first part titled Optimizing Coronary CTA with a focus on quality imaging and access to care. I am very thrilled to be joined by a panel of expert speakers. And I think all of us are aligned in the field around the importance of quality imaging. I think all of you are aware that in the 2021 U.S. multi-societal guidelines for chest pain, as well as international guidelines, that coronary CTA has been elevated in its recommendation for patient care. For example, in the U.S. guidelines, it was the only non-invasive test given a Class 1 level of evidence A recommendation. What we've seen as a field is exponential growth, with centers that were previously doing coronary CTA seeing expanded volumes and increasing demand for the utilization of this great technology, as well as new growth in sites starting cardiac CT programs around the world. And I think it's all incumbent on the society and the field to ensure that as we do so, to deliver the very highest quality outcomes for our patients, that we continue to focus on quality and also learn how to ensure adequate access to care to patients with this increasing demand. And I think many of you who are already practicing in CT have already seen and feel this on a daily basis. And so I'm very pleased today to be joined by three experts in the field who will give us some best practices and talk to us about how they do cardiac CT in the very highest quality way. And I'll just introduce them in the order in what they're going to be speaking us today, but these are people that truly need no introduction. I will be joined today by Dr. Eric Williamson. As you know, Dr. Williamson is a cardiovascular radiologist at Mayo Clinic in Rochester, Minnesota, and a past president of the SCCT. And he will be talking today about optimizing the practice of coronary CTA quality and access at a very high level. But then we're going to step down to the level of the patient and at the scanner and review the role of the technologist. These are the tip of the spear in performing high quality CTA. This is going to be led by Patricia Dickson, who is the Director of Operations, one of the world's leading CT technologists and former board of director member of the SCCT. And then lastly, but certainly not least, is Dr. Lance Sullenberger, who is the Chief Operating Officer and an expert in advanced cardiovascular imaging. He's a Chief Operating Officer at Capital Cardiology Associates in Albany, New York, practice that has been very forward-thinking and leading the world in how they use CT. And he's going to speak about increasing access through the use of same-day coronary CTA and how to implement coronary CTA in a chest pain outpatient clinic. And so we'll get this started and introduce Dr. Williamson with the title again, Optimizing the Practice of Coronary CTA, Quality and Access. I'll turn it over to you, Eric.
Awesome. Thanks very much, Todd. I appreciate that introduction. And as Todd has mentioned, we'll be talking today, or I'll be focusing my remarks today, talking specifically on access issues and how that affects what we do in coronary CT angiography and cardiac CT in general. And so as we think about, I have no relevant disclosures for the material in question. As we think about the issues that we're talking about, I want you to put yourself in the position of somebody who has just come on to staff, say, and they've been asked to start up a coronary CT angiography program, and the institution you're working for has invested in a bright, shiny new building for you, and they have a gorgeous lobby with a check-in desk that you can see out here. That's well set up, absolutely ready to start receiving patients. And maybe most importantly, or maybe most excitingly to you, they've also purchased you the latest and greatest equipment for you to begin your coronary CT angiography service. But you'll notice what is missing from each one of these pictures, right? There are no people in these pictures, and yet we know inherently, right, based on our practice in medical school residency as a technologist or an allied health staff, we know that quality of and access to a cardiac CT service is completely dependent on optimal staffing, right? And so I'm going to come back to this, but really it is staffing that we're going to talk about. It's going to be making sure that you have the best people working in your practice, whether they're checking patients in or whether they're performing the scan at the scanner, or whether they're the ones reading and interpreting those scans. So again, we're going to be focusing mostly on staffing and what the issues are. And the issues facing all of us are absolutely manifest. We know that we're in a time right now of significant financial headwinds. We know that if we can't manage our business profitably, no money, no mission. And there are a number of different factors in the market that, as Dr. Villines has already mentioned, you're probably feeling yourself. Whether it is that your expenses are rising, whether it's that your payer mix is changing over time and your government funding is diminishing and the market is volatile. But we know that there are financial issues facing all of us who work in healthcare in general, but certainly in coronary CT angiography specifically. And one that we don't really think about, or at least I don't really think about very much, is the way the rising interest rates are affecting all of us. Coronary CT angiography is a capital intensive business. You have to buy a scanner. You have to make sure that you have adequate space to perform these examinations. So the increases in the interest rate are kind of a hidden cost that increase for all of us and are translated to those of us who are trying to provide these services to our patients. So keeping this in mind as the background that we all work in, there are significant financial pressures facing all of us. And these are not just pressures that we feel in the United States. These are maps that are taken from a beautiful paper published by the current president of the FSCCT, Ed Nickel, and his colleagues, who looked at the data from the NICE 95. Sorry about the phone in the background. The data from NICE from the UK, looking in 2016 about the distribution of equipment. In other words, where are the scanners in the United Kingdom, and specifically, where are the scanners that can be used to perform coronary CT angiography? And what they found, unsurprisingly, was that despite the change in the guidelines and despite the directive from the country that, as Dr. Villines has mentioned, that coronary CT angiography is a first-line test for chest pain, the equipment that existed in the United Kingdom was not adequate to meet the demand, and the trained personnel that existed across the country were similarly not adequate to meet the demand that was known. These are scarce resources that we're talking about in coronary CT angiography. Of course, our situation in the United States is somewhat different. We are not deficient in the number of CT scanners we own. This is a graph from Statista.com showing the number of CT scanners per million population. And you can see with that cute little blue arrow there in the upper right-hand corner that the United States trails only Japan, Australia, and Iceland in terms of the number, essentially the per capita CT scanners. We have 45 CT scanners approximately per million residents. We use that massive scanner fleet to perform 75 million CT scans a year in the United States, and that works out to be about 1 scan per 5 people per year. So tomorrow night, if you're out with 4 of your friends sitting around a table, you might look around and say, well, who here got a CT scan last year? And if you don't raise your hand, be sure that we will get to you eventually, right? Roughly once every 5 years, you should be getting a CT scan. Those are the numbers. That's what that looks like. So if we have so many CT scanners, how are we doing with regard to the way that we administer care, the way that we perform coronary CT angiography? These are numbers from a study that Joanne Olson, the CEO of FSCCT, commissioned back in the days when I was president of the society. And what she showed with these data, these are Medicare claims data, she showed that despite our massive CT fleet, we're not getting CT scans, coronary CT angiography, to every individual patient in an equal or equitable way. What we found was that rural individuals and non-white individuals were disproportionately disadvantaged with regard to access to CT, right? If you're rural, if you're non-white, you're less likely to get a coronary CT angiogram based on Medicare claims data. Perhaps unsurprisingly, even if you look within, for instance, an urban environment, and we begin to stratify patients based on income, we found that within high-income regions, a patient was twice as likely to get a coronary CT angiogram as if they were from a low-income region. So these data, when you take them all together, they suggest that non-white, poor residents of rural environments are less likely than they should be to get a coronary CT angiogram. And when I look at this, a lot of numbers, several pages, I'm throwing you these spreadsheet data, but I think the take-home message for all of us is when it comes to coronary CT angiography, we don't have a capacity issue. What we have is an access issue. If we could make the entire capacity of our CT fleet available to all of our patients, we should have adequate access. So maybe then the issue in the United States is not so much the equipment, maybe the issue is more the personnel. And I think that's what you find if you look into the numbers. And again, this was me delving into the ACC job board. I think this was maybe midway through 2022. You look at the ACC job board, there were about roughly 1,200 cardiology positions open, which is a shame because we only train about 1,000 cardiologists a year. In other words, year over year, we go into debt by roughly 100 cardiologists compared to the amount of work we want to have done and the number of people meeting that demand. If you look within radiology, the situation's honestly probably even worse. We go down by about 200 radiologist jobs every year. Physicians who are trained to do the work that we want them to do are a scarce resource in our environment. And if you think the problem is bad with regard to radiologists and cardiologists, it's far worse with regard to our allied health staff colleagues. And if you work in the sphere, you know this is true, right? There are 25,000 open allied health staff positions across the country. Again, this is as of 2022. That's nuts to me, how many people we need, right, to staff the scanners that already exist that we cannot meet, right? And this is, again, I'm not the first person to tell you this, right? If you look at Wall Street Journal, you look at Bloomberg, you can see that there is a labor shortage all across our industry. And this is the entire job market. But I think those of us who work in frontline healthcare feel this very acutely, right? We feel this very low unemployment rate and therefore low labor supply really, really acutely. So if this is the problem, how exactly are we going to address it within cardiac CT? We have to, in short, we have to compete for talent, right? In the short term, we have to compete with talent. We have to provide a compelling case for young trainees, right, to choose our specialty, right? And the way that we do that is we identify opportunities for advancement, we make sure that we recognize their achievements, and we give them the opportunity to develop their skills. This is the way that we're going to be able to compete with other medical specialties, to identify that talent and make sure that they want to come join us in the field of cardiac CT. Because we know that employees are looking for more than just a paycheck. They're looking for more than just a short workday. They seek personal value and they seek purpose at work. And there's an opportunity here for us in cardiac CT to provide them that purpose. The same thing is, in the same way, we need to be able to invest in mentorship, right? And this is a page from the website. This is the FSCCT Future Leaders Program. We need to make sure that in addition to getting physicians, young physicians, to enter our programs, that we're able to mentor them, provide them opportunities, and make sure that we have a way for them to move forward. And overall, and I want to emphasize this, as we do that, as we invest in mentorship, we need to create a culture of participation, because that culture of participation is really going to be necessary for us to then take the next step and recruit our allied health staff colleagues as well. Just as we're competing for talent with regard to on the physician side, we're competing for talent on the allied health staff side as well. And we know that our frontline allied health staff colleagues are looking for respect and acknowledgement. They're looking, of course, for a satisfying work environment, but specifically, they're looking for ongoing skill development. And there's an opportunity here, obviously, for us to provide that environment, that kind of environment that allows them to develop their skills within FSCCT, within cardiac CT in general. Again, you see me pulling a lot of data directly from the FSCCT website, but this is the program for providing a technologist certificate of competency. This education is tailored to CT technologists. It's available online and it's a competitive cost. We want to make sure that we're matching education to the audience, that we're meeting technologists and other allied health staff where they live, providing them the education that they need so that we can over time really build a community so that again we're all working together in pursuit of that community that I think we're all seeking with regard to our professional development. So I realize I'm coming up on time here. They'll wrap it up. This is my final slide. Again, just in summary, I want to remind everybody here that quality of and access to a cardiac CT service depends intrinsically on optimal staffing. The way for us to make sure that we have that optimal staffing so that our patients get the access they need, we need to expand our reach by training allied health staff and increasing awareness. We also need to increase our pipeline by investing in trainee mentorship and directed technologist training programs, again, so that we can create the community that we need to provide care to our patients that they need. Thank you very much for your attention.
Wow, thanks so much, Eric. And I'll just invite all our speakers to come back on to the panel as we discuss this. And so I have a couple of questions for you, Eric, and I encourage all of our live listeners to feel free to send in questions via the question and answer panel or the chat panel. We'd love to get to as many of those as we can during this 1 hour webinar. So you mentioned this issue of health equity, and that is sobering statistics to see. We see this, obviously across other domains of healthcare beyond just imaging.
Yeah.
And then you also mentioned the issue of staffing and training. And maybe you can comment, on the training side of things. Where are we with radiology and cardiology training? Because it has been humbling for me to see how long, if you think back to 2005 when we really saw the evidence of 64-slice scanning, how long it has taken for our training programs to really provide cardiologists and radiologists adequate opportunities to learn this skill. And I think we're kind of seeing the downstream effects of that from a reader standpoint. This is just obviously the physician side of it. We'll come back and talk a little bit about the technologist side.
Yeah. Well, and I think the technologist side is there's a huge issue there, and we certainly want to hear from Patty when we talk about that. But, you think about, and Todd, I know you've done a ton of work in this regard, at looking at training programs and trying to develop them. When you look at the history of FSCCT, and you mentioned 2005 with the advent of the real emergence of the 64-slice scanning, I think it is not a coincidence, right, that the first meeting of the FSCCT was in 2006, right? You remember going to that Marriott over in Arlington, Virginia, and meeting all the people who were fired up about the new technology and wanted to develop themselves and their colleagues by developing training programs. You look at where we've come since 2006 to today, it's incredible the number of places that didn't know how to spell cardiac CT, back in 2005, and now are in a position where they're offering training programs. There's still a ton of work to be done. There's a ton of work to be done because, as we know, with the explosion recently, say the last 3 to 5 years, and in the demand for cardiac CT services, even our anticipated growth in training programs, and the training programs have grown, has not kept up with demand. In the short term, we are going to have to compete with, no offense, echocardiography and nuclear medicine labs, right? We're going to have to be able to convince trainees that there's a reason for them to invest in doing cardiac CT, and that is going to be to the detriment of these other programs, right? We have to recruit folks. We have to recruit both radiologists and cardiologists to do what we do, and then we have to provide training programs opportunities for them to go and to do cardiac CT. And so that the growth, even as much as it's grown, needs to grow more, and we need to continue to invest in those programs. And Patty, I do want to give you time to talk about that because, Todd, you think about the maturity of our programs on the physician side, we're way further behind that when it comes to training our technologist colleagues. And Patty, I wonder if you have comments about that as well.
I do think that we need to increase our training platforms, but a lot of the time for CT technologists, it comes on the job. So it's when you're able to find those technologists having a strong mentor program so that they can work and have enough time to grasp what they need to grasp. A lot of times we're just so eager for bodies in the departments that we're bringing people on, and we just need them to go. So it's taken that time to really develop a mentorship program right within each individual site.
So Eric, I have two quick questions for you. And these are questions I often get. Number one is, we know a lot of healthcare systems, perhaps like Mayo and others, they have traditionally viewed coronary and cardiac CT as being only done in the main campus, right? It's a highly specialized test. You got to go to the hospital for that one.
Yep.
But we know that there's a push now to move imaging closer where patients are and where they live. Yep. So maybe any advice on how we transition cardiac CT to become more accessible in the community while maintaining quality? And then a similar question, I get a question a lot, is how do I make the case to my administration that is a good thing to do when the reimbursement for CT is so low, to grow or start new CT programs? Any advice from the Mayo Clinic perspective? And I know Lance will have a lot of great advice on that question as well.
Absolutely. And we'll throw it over to Lance in just a second. The thing that I would say from a shortcut standpoint, Todd, is the FSCCT starter kit, right? Again, I mentioned Joanne Olson several times, but she really spearheaded the development of a starter kit for programs that have not done cardiac CT in the past, but have the capability, own the machine, and simply don't have the financial wherewithal, and don't have the individuals trained. There's an entire section of the website, the FSCCT website, that allows you opportunities to, whether it's spreadsheets to convince your administrators that this is a lucrative thing to do, or whether it is specific advice with regard to how to get credentialed and how to stay accredited, kind of thing. So that's what I would say up front. But from a practical standpoint, what we've done at our institution is we have a really strong partnership between radiology and cardiology, right? And that's been absolutely crucial for, we know that we can operate these machines effectively, cost effectively, because radiology has been doing that for years. And we know that we can utilize these tests appropriately for the benefit of our patients, right? Because that's something that cardiology has been really involved with over years. Having that strong partnership has been absolutely key in our environment, Todd. And I would recommend that for everybody.
Yeah, Lance, any thoughts on how to grow programs, start programs, how to make the case for CT?
Yeah, I mean, as you say, reimbursement for CT is not as robust as other modalities such as nuclear, certainly PET. Yet as cardiologists, we're supposed to provide the best test for the individual patient in front of us. And CT many times is that best test. So I think where you can gain hand with CT is certainly with any sort of quality initiatives or pay for performance, where you're decreasing the number of inappropriate caths, and certainly making a difference in terms of statin utilization or aspirin utilization for patients who have non-obstructive coronary disease that would not otherwise be recognized by, let's say, SPECT imaging.
Great. Well, thank you all. I'm very excited to move on to our next talk, and coming to us will be Patricia Dickson. Again, I mentioned she's the Director of Operations at Capital Cardiology Associates, a former board of director, member of the FSCCT, and she'll be speaking to us on the role of the technologist in optimizing image quality. Thanks, Patricia. Hey, Patricia, you'll just have to come off mute.
So good day. Like Dr. Villines said, I'm Patricia Dickson. I'm the Director of Operations at Capital Cardiology Associates in Albany, New York, and I have over 19 years of cardiac CT experience, which I look forward to sharing with you as we discuss the role of the CT technologist in optimizing image quality. So I recently had an eye exam, and as the ophthalmologist was going between image A and B, asking which looked clearer, I started to think about image quality. And although I can't explain why, I started to compare my eye exam to cardiac image quality. So if this image is what you're used to seeing, by the end of this discussion, you will have a new vision. If I translate the last CT slide into CT images, hopefully you don't have to interpret too many images that look like A or B. But we know that this does happen. So our focus for the next 10 minutes is going to be on what can we do to achieve an image that looks more like C, but preferably D. So quality for the technologist begins with the basics. My discussion will begin with the importance of communication and work through positioning, protocols, appropriate contrast, utilizing available software to minimize dose without affecting the image quality. There are many aspects of patient communication that need to be in place. Communication needs to start upon initial contact for the patient. For many, patient instructions include no caffeine, exercise, and tobacco, and no eating for 4 to 6 hours prior. It is also a good idea to inform the patients of how long they can expect to be at your facility, along with a brief explanation of the tests they will receive. So on arrival, the nurse or technologist will review patient history, obtain consent, vitals, start an IV, and give medications if the heart rate is elevated. An 18 to 20 gauge IV needs to be placed in the right antecubital to reduce streak artifact from the contrast. Although wide detector units can acquire images with higher heart rates, the goal should be to scan with heart rates less than 60 beats per minute. So oral and IV medication should be available if necessary. Having protocols for administering cardiac medications will assist with efficiency for the nursing staff. An optimal heart rate should be achieved prior to bringing the patient into the exam room. Practicing breathing instructions is crucial. Not only will it indicate where the heart rate will be upon image acquisition, it will prepare the patient for the live scan. So communication does extend to the discharge of the patient by informing them what to expect, when the results will be ready, to drink a lot of water, and what to look for in case they develop an allergy. When positioning the patient, first and foremost, ensure comfort. Pillows under their knees, blankets, have them bring their arms over their head and move the patient in and out of the gantry to make sure that their elbows won't hit the machine. This step allows the technologist to observe if the patient is tensing their chest muscles, which would then cause artifact on the ECG. And on the topic of the ECG, it's important to shave any patients that need to be and place the leads with their arms over their head to ensure the ECG pads are adhering appropriately while the patient is in the position for the scan. And should there not be a good tracing, then move the leads to other locations. For example, maybe just behind the shoulders or on their wrist. Centering the patient is important for automatic dose modulation. The technologist should utilize the laser lights with the Z-axis mid-patient mass and the longitudinal line midline to the body, if not slightly offset to the left. By doing these few initial steps, our quality begins to become more clear. So the next step that's important to quality is standardized protocols. Providing the techs with precise guidelines will not only assist with efficiency, but provide minimal disruptions for the providers. Retrospective techniques should really be utilized only if clinical indication requires an ejection fraction. And to minimize radiation dose for retrospective scanning, I would use modulating MA. If possible, prospective scanning should be utilized with specific parameters. The technologist will be able to utilize padding based on heart rate. A heart rate of less than 65 beats per minute, padding could be set to 65 to 75% of the R to R. Where if the heart rate is 65 to, let's say, 72 or 3, I would increase padding to 60 to 80%, and heart rates over 73, I would have that padding extended 35 to 80%. I found following intervals work best to prevent motion in the different arteries. So if I need to look at the coronary artery, I would go back to 40% of the R to R interval. For the left anterior descending, I focus 60 to 70%. And for the left circumflex, I would look at 50 to 60. So in coronary CTA, a large volume of contrast is needed to be administered at a sufficiently high rate to reach and maintain a homogeneously high concentration throughout data acquisition. And the optimal arterial enhancement in CTA exams is between 250 to 300 Hounsfield units. To achieve this, again, you will need an 18 to 20 gauge IV in the right AC, a dual head injector, a triphasic injection protocol with a rate of about 5 to 6 cc a second that will contain an undiluted contrast bolus, followed by a diluted contrast chaser, and then finally saline. The dilution of contrast media can be varied, but this dilution should provide diminished right heart attenuation. So in times when cardiac CT can be performed within a single heartbeat, optimal contrast enhancement needs exact timing. A fixed delayed is not recommended in cardiac CT. A test bolus and bolus tracking are both techniques to calculate delay. With a test bolus, attenuation is measured in a region of interest while contrast is injected. When a predefined threshold is reached, which is usually 100 to 150 Hounsfield units, breathing commands start and the scan is triggered automatically. In comparison, the bolus tracking technique monitors a small amount of contrast, about 10 to 20 milliliters. In a second step, an ROI is placed and the attenuation curve is displayed. Based on this curve, additional time will be added before the scan starts. The advantage of bolus tracking is that it serves as a trial run to ensure correct IV function, and patients get used to the unusual sensations of the contrast injection. The drawbacks of bolus tracking technique is the additional minimal volume of contrast that's needed, and the disadvantage to the test bolus method is potentially missing optimal enhancement and risk repeating the exam. So there are several advances in software that can assist in image quality. Iterative reconstruction has been shown to reduce image noise and reduction in radiation doses. Motion artifact, which is one of the most popular important limitations in coronary CTA, affects overall accuracy. So techniques such as heart rate control, faster scanning, wider detectors, and dual source technologies are ways to limit motion artifact. Occurrences of arrhythmia causes significant issues with missing data and artifacts in coronary CTA. Siemens' recent advances in arrhythmia detection include using a complex algorithm to enable stopping the scan when arrhythmia occurs and restarting the scan after arrhythmia subsides to enable capturing data in the right cardiac cycles. So all the steps that we have already discussed do play a role in radiation dose. Minimizing dose begins with proper positioning, utilizing standardized protocols, appropriate contrast enhancement. And as explained, the radiation dose and quality do go hand in hand. So performing the outlined steps and taking the time for the technologist to correct any issues as they occur is going to provide the interpreting provider with high quality images and will bring everything into focus. Now, if this slide is not optimal, maybe it's time that you get an eye exam. Thank you.
Wow. Well, thank you so much, Patricia. And how exciting it is to go back to the basics and just remind us of the importance of institutional protocols, the importance of having, well-trained technologists at the scanner delivering high quality scans, and reminding us that it's the fundamentals that matter, and they allow us to get the very best scans at the lowest radiation doses that are of the highest diagnostic quality. Thank you, and to all of our technologists, because I know that the entire field really of coronary and cardiac CT imaging is dependent on you all. And you heard from Eric and the importance of getting more of our technologists trained and more mentorship, as you mentioned in your talk. So And I'll just remind folks, obviously, there are SCCT guidelines that can help programs, but the importance of working, with your specific scanner to optimizing your protocols to get the very best scan quality. So here's a quick question, and I'll throw this out to the group, Lance, Patricia, and Eric, from the audience. As for beta blockade, do you prefer IV or oral? And what would be considered the max dose? So thoughts on beta blockade?
I can speak just to our protocols here. We like to start with an oral beta blocker. Sometimes we'll have the patient come at their scheduled time. We'll look at their heart rate upon initial setup. And then if it's high, we'll start with an oral beta blocker and then move on to IV if necessary. And then I think that the maximum amount would be dependent on those standardized protocols put forth by the interpreting cardiologist. And I don't want to speak for exact amounts because I'm not the physician, but they are important to have in place for the nursing staff.
Yeah, I would say the max PO that we usually give is 100 on the morning of. IV, I'll go up to 5 milligrams IV times 4 to see if I can get their heart rate down. If they've gotten that much beta blocker and their heart rate's not coming down, you're not going to be able to get a good scan. So we'll go with an alternative method at that point.
Yeah, I think, Todd, we probably use a slightly different protocol. We don't use much oral in our practice because we're a radiology shop. So we're trying to get patients through pretty quickly, and what tends to work for us is IV on the table. And so we don't use oral first, not because we don't like it, but because we struggle to get it to the patient early enough for it to have an effect, right? So the patients don't spend as much time as in our department as we might like them to. So we use oral, and Lance, I feel the same way that you do, right? If you've gone to 5 and you haven't seen enough effect, it's probably not going to happen for you. So.
Yeah, well, great advice, and obviously the importance of heart rate control. We've also seen some, with certain scanners like dual source scanners in patients who aren't responsive to beta blockers, or maybe just rolled in and don't have the time to give beta blockers. Even doing end-systolic imaging is another approach, and that's something that we've done at the University of Virginia, where we continue to do clinical care, and that's something that we've used. But I think we always default to having good heart rate control as the best you can do it. So the importance of that is obvious. A couple other questions have come in, and we'll try to get to these quickly. In a comment here, IV is short term, et cetera. Maybe use oral. I think we've all experienced that. People have taken oral, that we get a more stable and perhaps enduring heart rate control. IV nitro. I know our practices, we always give nitro. I guess from Lance and Patricia and Eric, how much nitro? When do you give it? Do you always give it?
We always give it. The mainstay of our practice is sublingual, but there's a push now to do. I know several groups do paste. We've never tried that, and there are of course many groups that do the spray as well. But for this point, we're sublingual, same as normal. I'm curious what other people's experience has been.
Yeah, we do
sublingual. Yeah.
Sublingual. Mm-hmm. The only time we don't give it is if there's a blood pressure issue. Yep. that would preclude it, or Viagra use or something like that.
Yep.
Terrific. Well, I think for the sake of time, maybe we'll move on. I think there are some sites that, like at MGH, that actually, even for throughput purposes, throw a nitro patch when people walk in the door, and they've really timed their peak effect and timing based on that. So it's important to, kind of really think about your efficiency of operations. You mentioned, Eric, I think, if you're not able to get people oral, that's sometimes a little bit of a challenge and a wait time. So I think just being cognizant of that. And again, the SCCT guidelines really stress that you give nitro in all patients unless it's medically contraindicated, and that heart rate control should be aimed for. But again, how you achieve that is going to be institution dependent. And we even know some people using ivabradine in patients who don't have, who maybe have contraindications to beta blocker. And that's something we've done a little bit of when really needed. Well, I think for the sake of time, we'll move on. And I'm really excited to hear from our next speaker, Lance Sullenberger. As I mentioned, Lance is Chief Operating Officer, a cardiologist trained in advanced imaging. He's at Capital Cardiology Associates, working very closely with Patricia, and someone that I've known and learned so much from, going back to our time together at Walter Reed Medical Center in the DC area. And Lance is going to be speaking speaking to something that I think is really exciting with regards to access to care and the use of same-day coronary CTA in a chest pain unit. So I'll turn it over to you, Lance, and I look forward to the discussion following this talk.
Great. I really appreciate the opportunity to be here. Like Todd said, I've been doing coronary CTA with Todd all the way back to Walter Reed about the last 17 years. In fact, we were at the first FSCCT meeting in Arlington, Virginia. I remember it well. I'm going to speak about one specific aspect of our practice, which has been of interest, which is the use of coronary CTA angiography in our enhanced cardiac access area of our office. So just a little background, Capital Cardiology Associates, located in the capital region of New York State, is a large cardiology practice. We have 35 cardiologists, which run the gamut from non-invasive to electrophysiologists, structural, interventional, and advanced heart failure. And we have about 21 advanced practitioners with 3 major office locations. In 2013, we really tried to address a problem that we had seen, which was way too many patients in the emergency rooms at local hospitals with possible cardiac symptoms. And by the time we were consulted to evaluate them, it became, how could you say, like messy, because the patients had been there for a while, they were on observation status. As anybody knows, you don't have much control over imaging out of the emergency room as a cardiologist, because it's run by radiologists. Hospitalists would get consulted first and would do testing that they thought they needed, which wasn't necessarily what a cardiologist would say. And then you had a lot of patients going to observation admissions that we as cardiologists said, what, this patient never needed to be on observation. They clearly had non-cardiac chest pain. So what we decided is, like, why don't we just open an urgent care within one of our cardiology offices, our main cardiology office in Albany, and open it to patients with potential cardiac symptoms, so that patients, instead of having to go to an emergency room or being sent to an emergency room by their primary care provider, they could come into our office and we would accept them as the same day and do an evaluation. And the good news is we would control the imaging and we could avoid unnecessary admissions. So we had really no idea how this would work or grow. But we created, just within an area of our office, so within our office itself that's also seeing regularly scheduled patients, 6 bays, and you see those here. You could see the type of bay that we used is more of a furniture rather than building rooms, so that we could depreciate the expense. We purchased telemetry for these bays, hired a nurse with cardiac experience. We had an in-house lab already, but we changed it so that we could get stat, troponin, and BNPs, and then educated our nurses who answer phones to tell them, instead of, if somebody calls in, instead of telling that patient who has some sort of symptom to go to the emergency room, just tell them to come into the office. And then we did a lot of outreach to local PCPs as well as emergency rooms to say, if you have a patient, who has a symptom that you think could be cardiac, or you want them evaluated, rather than having to send them to the emergency room, or rather than keeping them in their emergency room, just send them to our office. So those patients would include patients with chest pain, shortness of breath, palpitations, significant hypertension, AFib with RVR, urgent pre-ops, syncope. And it involves, when the patient arrives, they are triaged, they get labs, EKG, and vital signs, and they're put into one of our bays. Over time, we've had, because of the growth, we now have an advanced practitioner do the initial evaluation, and then they're seen by a cardiologist. All the diagnostic testing is add-on. So we can do stress testing, we can do echo, CT scanning, which would include calcium scoring, coronary CT angiography. We do a lot of triple rule outs, and we do a lot of chest CTs for PE. We also have mobile telemetry and can do ultrasound for DVT or vascular studies. So we started this in 2014, and you can see that, initially for that year, there was about 700 visits in that specific area of our office, so in our urgent care. And then somewhere, it took about 3 years, and then we hit the tipping point, and it really took off. And as of last year, there were almost 12,000 visits to just the urgent care area of our office. And that was comprised of over 9,000 distinct patients. So these were each individual patients coming in. It's sort of grown into its own self and is really one of the community's best assets, because primary care providers tell me all the time they're so happy that they don't have to send a patient to an emergency room, because the patients just want to be seen, and especially the way emergency rooms have really changed since the pandemic. And you can see even in 2020, we had a small dip, but we never closed our doors during the entire pandemic. And we had a lot of patients who had shortness of breath or chest discomfort who did not want to go to emergency rooms. So we just found a way to protect ourselves and protect our patients, and see people and keep our doors open. So currently we have 2 of these sites running. One is in our Albany office, which has about 14 bays. And on average, 41 patients per day come in, with about a third of those coming in as new patients who have never been in our office before. And a second site in Clifton Park, which is about 20 miles north of Albany. We have 12 bays there. And it's a newer office, but already average about 21 patients per day, with, again, about a third of them being new patients. When we originally set this up, I thought maybe we would send home 85% of the patients. We send home more than 95% of the patients. The other patients that come in that need to be admitted, we either do direct admissions to the hospital, send them to the cath lab if they have truly unstable symptoms or myocardial infarction, or if a lot of times patients will come in with shortness of breath, and on lab evaluation we found out they're significantly anemic or they have a GI bleed, and we'll send those patients to the emergency room. We could not run our urgent cares, our enhanced cardiac access, without CT imaging. We have 2 cardiograph scanners, one in each of our sites, and we utilize them about 12% of all visits. Now, the utilization varies. We do everything from calcium scoring to coronary CTAs to PE scans to triple rule outs. And it really depends on what the question is that's trying to be answered. I always think of risk assessment as an iterative process. So I've got the initial story, the blood work, the EKG. You add a calcium score onto it. That changes things. And then you figure out, do I need to do a stress test, or do I just run a coronary CTA to answer the question? So there's lots of different ways in which we utilize our CT scanner in this setting. But what I could say is that we could never do what we do without our CT scanning. So, it's critical for ruling out pulmonary embolism, ruling out obstructive coronary disease, and overall changing the risk assessment. It certainly increases patient throughput and facilitates safe discharge. Here in our offices, we're much more likely to do a same-day stat coronary CTA and send somebody home, and they never do that in the emergency room. It's always too much work to beta block people or do whatever for the local emergency room. So I've found that CT imaging is really critical to the whole process. So I'm happy to take any questions to discuss this, but this very key part of our caring for our patients here locally.
Wow. Yeah, thanks so much for that, Lance. And I think this is, really kind of speaks to what Eric hit on initially is this model of, with the goal of getting access to care, of thinking differently. And, I think all of us have been at systems where, you have to go to the main campus of the hospital, right, to get, a coronary CT. And in my experience, and I think in all of yours, we've seen that the protocols, the vendor, the scanners, that, if you do that well, it can be exportable, right? You know, if you
Right.
train your technologists, we know that scanners are becoming increasingly automated with regards to dose selection, the contrast timing is, you know, as Patricia reminded us, you have to know how to do that well, but it's, you know, if you're well trained, the protocols work. And so this is really exciting to me, you know, as a past president of the SCC, to see this move out of the ivory towers into the communities. And what you just described, I think, is really cutting edge, forward thinking, and exciting. Maybe my first question, Lance, is, you know, what did you get any pushback? I mean, in the community with your I mean, how did people react to doing, you know, same day coronary CTA, small footprint scanners, not in the typical, you know, emergency room setting?
Yeah, that's a good question. So, you know, capital cardiology has been doing CTA since 2006. We had a VCT scanner up until about 2019. And there's always payers who will lag behind where the data is going. But certainly over the last 4 years, it has become much less of an obstacle to get a same-day coronary CTA paid for, even without prior auth, because a lot of times we have to move these patients through, and so we're prior authing them later. And if you can just get somebody on the phone that you explain what you did, like, I saved this patient from going to an emergency room and you paying 10 times what you have paid for this CT scan, that they'll understand, and then, you know, approve it retroactively. From a standpoint of local facilities, I would say that ERs are, you know, we thought we'd get a lot of pushback from ERs when we initially opened and things, but ERs are happy to have us because it helps decrease some of their volume and burden. The urgent cares, these stand-up urgent cares that are around that aren't cardiac, but just urgent cares, they're always happy because they don't know a lot of cardiac stuff. So they're happy to have somewhere to send the patients rather than having them have to go to an emergency room. Or they can see them and say, you know what, why don't you just walk into their office tomorrow morning and you can get further evaluated.
No, terrific. And the volumes that you're saying are just tremendous. Are you using this outside of the acute chest pain? I mean, are many of these patients, you know, you're seeing someone in clinic, or you know, someone that's had chest pain for several months. I mean, are you using this to really, because, you know, we struggle with access to care. You know, someone has chest pain, you put in a consult to cardiology, sometimes it takes weeks to not see them, but after you see them, just getting a test sometimes takes a frustrating amount of time. I mean, have you looked at your turnaround time for patients who, even with chronic chest pain?
Yeah, so with our 2 scanners running, we do about a little over 5,000, maybe 5,500 scans a year. So our schedules are usually full. Any of these scans that are coming out of the urgent care are add-ons, and luckily I have great technologists who you know, are happy to add on patients and figure out a way to make it work. So yeah, we're doing these in addition. Our back, you know, like if you ordered a coronary CTA today on a patient we're seeing in the office, there's about a 4-week wait. We can get people in sooner if there's urgent, you know, if it's more urgent, but that's our routine turnaround right now. The other thing I would say is that you have to, as a cardiologist, figure out, you know, so when you're, I always ask my advanced practitioner, my other cardiologists who are staffing the urgent care, to just think about how to use the CT most effectively. Like the 45-year-old woman who comes in with atypical chest pain, CTA may be the absolute best test for that person to give a definitive assessment, rule them out as per guidelines. You know, you're good, you have nothing, don't worry, you know, you don't have anything to worry about. But it's not probably the best test if her heart rate's 100 because she's nervous. So those types of patients, what we may do is, while we're waiting for labs, have them get a calcium score. Then if the calcium score is 0, put them on a stress test. Then you've got a calcium score of 0, you know, in a normal stress test, which is different than just a stress test or a calcium score of 0, as opposed to somebody who, in the same situation, who has a heart rate of 65, we're going to do a coronary CTA on that patient.
Great. A quick question. You know, one of the things that we have seen, in the 2021 guidelines was this new definition of coronary disease, right? That coronary disease is now defined based on plaque on CT, not according to the traditional criteria of needing stenosis above a certain threshold or having prior MI or revascularization. And so how, maybe Lance and maybe at the Mayo Clinic with Eric, how are you following up these patients? You're doing more and more CT scans. We're seeing more and more plaque. And we even have the ability to do advanced plaque quantification, et cetera. But how are you, pairing what you're seeing on CT with following up these patients, ensuring optimized prevention? I know this is a challenge for a lot of practices, but an opportunity, I think, in my opinion, to drive better care.
Yeah. So for us, I'm sorry, Eric, I didn't mean to interrupt you there, but
yep.
Yeah, for us, if in general, if a patient has coronary calcification or coronary disease on CT imaging, if it's quantified and certainly above, you have a calcium score above 100, almost all of my colleagues and I are putting that patient on a statin and usually following up with them on a routine basis. That may be 6 months, that may be a year, depending on other factors, but making sure that all of their other risk factors are addressed and following that patient longitudinally. If it's just a little bit of plaque, less than 100, it's always debatable about what to do, other than obviously lifestyle modifications to get an early jump on prevention.
Yeah, I just would echo exactly what Lance said. It's a fascinating thing, of course, for those of us who've been looking at the coronary arteries using CT for over a decade. We've known for a long time that we were seeing coronary atherosclerotic disease, Todd, to your point, that wasn't being acknowledged using traditional definitions of this disease, right? But we knew it was there, and it's nice to see a recognition by the guidelines that non-obstructive coronary atherosclerotic disease is coronary atherosclerotic disease, right? And I think it's really beginning to drive home the point that plaque is maybe what matters more than the way we've always traditionally approached this disease, as a disease of functionally significant stenosis, right? There's always been a disconnect from my standpoint with regard to, well, we know that most heart attacks occur in patients with less than 50% stenosis, but I'm going to use somehow my focus in diagnosis is going to be on identifying functionally significance that never made sense to me in my head. And frankly, this acknowledgement is I think overdue, and Lance has outlined what I think is a very appropriate way to then approach it, right? If you have a quantification, we know this patient has coronary atherosclerotic disease. We need to do things like lifestyle modification, and we need to identify, what are the metrics that we're going to use to follow patients. Obviously, once you've started a patient on a statin, trying to follow them with serial coronary calcium, not a good idea, right? But identifying what our primary endpoint is, and then what our secondary endpoint is, and then driving toward that. Again, I have to agree with Lance, and just want to augment again the idea that we're now looking at plaque in a renewed way, and a way that's supported by guidelines, and it's overdue, but happy to be here.
Well, we've only got a couple minutes left, and so I just want for each of you, real quickly, within 30 seconds each, give our listeners kind of your best advice for those that are thinking of starting a new program or growing their CT program. Lessons learned. If you leave one parting tip of advice, and maybe we'll start with the technologist side, Patricia. What would you tell those that are at a CT lab that's about to get really busy or thinking of starting cardiac CT to make this go well and to get the best quality?
Well, first and foremost, I think it starts with training, and I think it will be successful if you have appropriate staffing, be able to keep things moving efficiently. So it does go back to the basics though, right? Dr. Villines, we need to have protocols in place. So every step of the way, we know what we're doing. So as long as you have those things in place, staffing, training, it should go smoothly.
Eric or Lance, any parting words of advice?
Lance, you want to go ahead?
Yeah, I would just say I like to think of, maybe it's because of mine and Todd's time in the Army, but I like to think of doing battle every day against cardiovascular disease, and that the ability to use CT imaging is a potent weapon, and that without CT imaging and that capability, you've really limited in what your capabilities are to make diagnosis and best treat patients.
Yeah, I think that honestly fantastic and inspiring, Lance. I think the thing that I would talk about first and foremost, Todd, is that it's easy to think about investments in equipment, and it's easy to neglect investments in your team. And I would say invest in your team, right? The environments that Lance and Patty and Patricia practice in, they've invested in their team, and you can see, right, it shows, and whether that's training or whether that's relationships, that investment in your team, it just absolutely pays dividends.
Well, thank you all for very insightful and educational webinar from people who are doing CT well and getting patients into the scanner who need it. Thank you all. I want to thank all of our listeners for attending. And I'll just remind you, this is part one. The second webinar in this two-part series will be titled Optimizing Coronary CTA. We're going to dig deep into reimbursement, reporting, and how to involve plaque and advanced plaque quantification in our second part of this webinar. And that will occur on Tuesday, December 12th, live at 11 a.m. Eastern. So thank you again.